I'd like to thank the committee for accepting my application for today, and I'd like to thank you all for being here at this time. Today, we're going to just go over briefly the application of the Integrative Cognitive Rehabilitation Psychotherapy model in people living with brain injury and co-occurring issues. Disclosures, I have no financial disclosures, and the non-financial disclosures include that I developed the ICRP model. I'm the co-founder of the Institute of the Integrative Cognitive Rehabilitation Psychotherapy, and I'm a board member of the Brain Injury Alliance of New Mexico and member of APA Division 22 and medical director of the Integrative Rehabilitation Psychotherapy for Brain Injury ECHO. So the problem that came up was that people with brain injury also had co-occurring issues of substance use and psychiatric issues such as depression, anxiety, and suicidality. And trying to find care for these people was very difficult. When you sent them to a substance use program, they would say that they weren't able to treat them because they had the brain injury. Or if you send them to a psychiatric hospital, they would say, again, that they weren't able to treat them because of the brain injury. And if they did get in, they also would get treatment in the sense because the traditional psychotherapies are not adapted to the cognitive brain injury secondary to the brain injury. So you have this mismatch going on between a lot of traditional therapies out there that have been shown to work, but not really addressing people in the brain injury population. So what happened was that I had actually some clients, and they had co-occurring issues. And coming from a psychiatry background, I was a clinical psychologist before a rehab psychologist. I basically just put several different therapeutic models together. I had the grace to be trained with a group of rehab therapists who showed me the ropes after I had already been trained in the clinical world. And so we just started putting together the different components, both on the inpatient unit and the outpatient unit. So what we have is an integrative cognitive rehabilitation psychotherapy model, which allows for a structure to apply 3 modes of therapy across 8 types of interventions in 4 stages of recovery. So this is just a drawing of all the different elements of the model. To the left, you can see that there's the developmental metacognitive approach that was developed by Latch and Stress. And it basically follows Luria's model, which has the basic skills on the bottom and the higher order skills on the top. So the premise is that you need to address and assess the basic skills or the core skills before addressing the executive functioning skills or the higher order skills. So you have alertness and stamina, processing speed and attention, and working memory, which is also known as short-term memory, on the bottom, and you need to be able to assess those skills. And then you have memory, which is very complicated. And then you have fluency, which is how quick you can do like simple math problems, or how fast you can read words. And then you have communication, which is how well you're communicating, which becomes a very complicated or complex process. And then at the top, you have executive functioning. So what the model encourages is, or asks for, is for a thorough assessment of these skills before starting therapy, so you can begin to know how you want to target therapy. The other thing that's involved is this notion of their readiness to change across different co-occurring issues. So what you see here is you see the 3 co-occurring issues that can be tied together within the therapy. You have the substance use, and then psychosocial issues, which include the psychiatric and the suicidality issues. And you'll see that there's a box, there's a label that says narrative. And in the psychosocial element, there's a process across the stages of recovery where the person begins to learn to tell their story. And so initially upon injury, their story is limited to maybe the devastation of the injury and maybe lack of hope and some helplessness. And as they go through, they begin to understand how the injury has affected them, what the things are that they can do to improve. They've improved in their therapies, and they begin to reconstruct their identity. And so the narrative is a dynamic process that changes over time. And then you also see cognitive rehabilitation, which has its own guidelines. It has its own best practices in evidence-based medicine. And what you're doing is you're taking that model and you're overlaying it over the other models with the notion that understanding what the cognitive strengths and weaknesses are of the person begins to affect the way that they see themselves, the way they interact with other people, and also the way that they will begin to utilize the skills that are being taught in the other therapies. Underneath that, you'll see 7 circles. There really should be 8, but I couldn't figure out how to fit 8 in there so it looked right. So these are the interventions that the therapist selects from along with the patient in determining how best to allow the person to return to as much of their premorbid functioning as possible, and to do as many of their activities of daily living independently as possible. So on the left, you see there's medicine. So there are medicines that can be used to help with attention and memory and processing speed, as well as some of the disinhibition issues or aggression or anger that might come up. And you always have to pay attention to the medical issues. And if possible, if people want complementary and alternative interventions, you can input those in as well. There's a cognitive training, which is a little different in the big picture, because a lot of the rehab therapies focus on the internal compensatory strategies, which you see, and the external compensatory strategies, which are in the circle as well. And when you help a person develop their external compensatory strategies, which is like using a smartphone, writing things down, using alarms, things like that, and your internal compensatory strategies, which is for some people, it's remembering to remember, or remembering to write something down, or to remember to use a calendar, or to ask someone to slow down, and those type of internal compensatory strategies. Once you've trained on those 2 things, a lot of therapists or rehab therapists begin to say that therapy is done. That's as much as we can get to, or that's as best we can get to. However, from a model of neuroplasticity, you begin to also add in cognitive training, and you follow some of Latch's work on reading fluency, and begin to see that you can do cognitive training. You can focus on some specific tasks. You can get the brain to change in some ways, so that you might not need as many external compensatory strategies as you started out with. So it's very important to begin to focus on the cognitive training over time, and this takes years, to begin to help improve recovery. And then there's the environmental strategies. These are essential. And when you're first starting out in therapy, they'll be heavy in environmental strategies, but there's 2 components to the environment. One is the context, the structure of the environment itself, whether or not they're dry erase boards, the lighting, the sound, how many people are there, or how much stimulation is there a place to rest, things like that. And then there's also the people in the environment, and how are they trained to begin to help you work through going from awareness of what has happened to you to insight, to what can I do about this? And how do these people provide support so that you're not feeling overstimulated or agitated or feeling really bad about yourself in a way that causes you to relapse into substance use or depression and suicidality. And then finally, there's the healthy living component. As we all know, that diet, exercise, and sleep is essential. So this allows the therapist to speak with the patient about what are the best ways to increase this very natural and healthy process of healing. And then finally, on the bottom, you'll see the 4 stages. There's there's surviving, healing, thriving, and ending. And surviving is the beginning of your journey after you've had a severe head injury or a moderate severe head injury, could even be a concussion, where you really get a lot of intensive therapies. You might be inpatient, then you might go to an intensive outpatient program and then step down into something that's a little less intensive. But at that time, you really are feeling overwhelmed. There's a lot of therapies going on. You're exhausted by the end of the day. And so you really aren't focusing too much on generalizing your skills. You really are trying to just identify who are you now and what are you going to do in the future. And then sometimes there's a surviving component for people who are chronic and far out in their recovery, and they've slipped through the cracks and they're just surviving day to day. They haven't really found some therapists and some doctors, healthcare providers to identify that they can get better. And so they're just sort of drifting. And that group also, you get them into maybe some intensive therapies just to get started. And then you begin to move them into the healing phase. And the healing phase is where a lot of the stress has been managed. It's decreased now. The people are now more settled. They have a focus on that they can do this. And they begin to have fewer hours of therapy during the week. And so the rehab therapist now can focus on several things simultaneously, and they have fewer of their other rehab therapists involved. So the issue becomes, what are some of the emergent issues that are prominent? Where are they with managing the depression and suicidality? Are they back to using substances? Why are they using substances, and how can they begin to treat or stop using substances? So we use these models that are fairly well researched. There's the motivational interviewing, there's relapse prevention that you can apply. And that's where the readiness to change comes in, and you can use motivational interviewing as one way to assess that. And as you move from the healing phase, where you're getting a lot of support in the office, you're getting your skills under control, you're not too stressed in the community, you begin to then talk about moving to the next stage, which is thriving, or another word is generalizing. A lot of rehab begins to fall apart between the skill of developing a skill in the office, where you do well in a very controlled setting, and then when you go home or you're in the environment, you just don't know how to generalize those skills. And you'll see many articles, research articles, on how a lot of therapies fail when you're trying to make this leap from training on a skill to generalizing. So here you begin to adjust your goals again. You begin to see what are the strengths and weaknesses that the person has that they can apply. Where are they becoming stressed? Are emergent issues showing up again? Are they beginning to feel suicidal, hopeless or helpless? Are they developing more of a substance use habit? And do they need to work on those skills simultaneously? And as they're developing their cognitive skills, do they need some booster sessions? Do they need to hone some of the skills that they had because they're not applying them correctly? So there's a lot of kind of trial and error and failure as they're moving into the thriving stage, because there's not as much support, and they're being asked to try things. What also is happening in this stage, we're also asking them to be their own self-advocate as much as they can. So they have to begin to develop more insight and begin to tell people what it is that they need to be successful in the community due to their cognitive issues. And then as they begin to move through that phase, then we move into the ending phase, where you're tapering therapy. You might do some booster sessions. You're checking to see how well they're maintaining any of the routines they develop to be successful, and any new issues that might have popped up, any anniversary issues that might have come up that caused them to really feel distressed or distraught or regress a little bit. And you begin to just talk about ending, how successful they've been, what strategies they've been using, and continue to increase insight and confidence, and then you can end. So the whole process requires a therapist to feel comfortable doing 3 therapies simultaneously. It also requires the need to work in at the least a multidisciplinary team where you begin to understand what other therapists are doing and other doctors. And also at best, a transdisciplinary team where there's overlap between you and the other therapists, and you begin to share a lot of the responsibilities of issues that are being addressed. So the highlights of the model include we are applying 3 therapy models simultaneously within each therapy session. So the therapist needs to begin to feel comfortable with switching gears in different therapy modalities without confusing the patient. And this requires some confidence on the therapist's side and some good support as they're learning to do 3 therapies simultaneously. And it adapts traditional therapies to the cognitive issues and examines the interaction between cognitive, psychosocial, and substance use issues. It also adjusts goals and objectives to the stage of recovery, the readiness to change, and the relevant cultural issues. So this is very much a relationship-centered model where the clinician and the patient both weighing in on what their values are and what's best at this time and how to move forward. An example is at the beginning when a client or a patient is very much wanting to use drugs and the therapist knows that's not a good idea. The therapist has to begin to tolerate that there will be some experimentation with it. There might be death in the sense with opioids. A patient could go out and use opioids at a level that they were using prior to, and it could be fatal. So the clinician has to be comfortable with beginning to address, well, if you're going to be using opioids, and let's find a way to do this so you can do it safely, because there's a good chance you will relapse. So the therapist has to be comfortable in that relationship. And at the end, when it comes time to be ending, the client and the therapist might be in different places. The client might be in a place where they're comfortable ending and having some disability and not returning to work full time, while the therapist might see the great potential that this person could return to work full time, but it's more the therapist's goal, not the client's goal. And so the therapist has to begin to acknowledge that the rate of recovery is wonderful, and you don't have to push on. And it can be vice versa, where a client is wanting to do some really high level activities and the therapist doesn't think that's going to be possible. And how do you begin to put those 2 different ideas together? So there's a process of working there. So the therapist is in a process of using their own experiences and their own feelings about what's going on in therapy, as well as how they feel as a therapist, to engage with the client. And there's a focus on transitioning from skill building to generalizing skills to the environment. And we've talked about how important this is. And finally, there's the ongoing assessment of emerging issues that allows for flexibility in attending to crises as they arise across stages of recovery. So crises are expected, and the therapist is basically checking in on every session to see where the person is and what is going on. And if a crisis shows up, the therapist has the permission to basically just slow down or stop the other exercises or goals that are being worked on to take care of the crisis, instead of shipping them out to another therapist or to an acute care unit or something. The therapist can actually say, okay, we're going to stop right now. We're going to take care of this. And if we need to have you go inpatient, we will, but if not, we'll take care of it now, instead of feeling like it's out of their hands and then having to send them to someplace else. So these are some of the benefits of it. And of course, the model needs to be researched more fully because it's only a few years old at this time. And it's a plug and play model where basically you can utilize the skills you have from the different types of therapies that you're comfortable using. And if they work within the therapy, that's great. And you can basically learn some other new interventions as you go along, as you begin to try to address different issues. So these are just some reference and contact information. I'd like to thank my colleagues in developing the model and the families that I've worked with over the years. And if you have more, would you like more information on how to engage in this model and learn more about it, just feel free to contact me. So I've left some time for us to ask questions if you have any. If not, then we can take a break or do whatever else is necessary. So, okay, how was that?
Yeah, thank you, Doc, for your wonderful presentation. Now floor is open for the questions, if anyone having. Can't see any question, Doc. Thank you so much for your presentation.